All right, so we're going to talk about collective bargaining or unions. Why are unions or collective bargaining, why is it important? Well, if you're working for a small organization, let's say there are 3 of you, you and 2 others. If you come up with an idea, it's pretty easy to get your ideas spread out to everybody else. There's only 2 other people. But if you work in a hospital may have hundreds of other nurses plus all the other staff. And if you have an idea, it might be a great idea, but it may never get to the person who can make decisions on it. But if you're part of an organization of other nurses, a network of nurses, you can put all your voices together, and just like that $5,000 check carries more weight than 1,000 $5 donations, a unified voice of many nurses together will usually have more impact. There is traditional and non-traditional collective bargainings. We'll talk about the difference in just a moment. And there are reasons to seek bargaining. There's also positive and negative aspects, just like everything else in life. So here's one question though we have to ask. Is traditional collective bargaining really appropriate for nurses? And I don't have an answer. I don't know. I've been talking all morning. Some people feel that professionals should not be a member of a union, that a union is for workers, teamsters for truck drivers, millwrights and pipe fitters and steam fitters for plumbers and those kind of people, and electrical unions for electricians, service workers for housekeepers and maids in hotels. So some people believe that unions are only designed for what's considered blue-collar workers. Blue-collar, that's an old term. There's blue-collar and white-collar. And this is not the blue-collar I'm talking about. In the old days, it was common for workers to wear these heavy-duty clothes that were generally blue or commonly blue. So blue-collar meant you were a worker. White-collar meant you worked in an office with a tie. So many people think blue-collar jobs are appropriate for nursing, for unions. White-collar are not. Nurses, some nurses are in unions, some aren't. It depends on the part of the country. There are not many union nurses in Wisconsin, but there are some. If you are a nurse for some county organizations, you are a member of a union. As a nurse, I'm a nurse, and I'm a member of an educators union because I teach. But when I worked at Aurora Healthcare, I was not a member of a union. So it varies from job to job, place to place. In some parts of the country, California, a lot of union nurses work in hospitals. So it's variable. Now, so some people say that nurses shouldn't be in a union because we're essentially white collar. We are professionals. What about teachers? Teachers are professionals and they have a union. Should they be in a union? I don't know. They are, always have been. Again, those are opinions. But that's what a union is for. A union is to collect voices and make sure that one message, one voice is presented to the public. When did collective bargaining begin for healthcare? It started in 1965 when Medicare and Medicaid began. Medicare and Medicaid provided a major change to hospitals. It changed reimbursements. It changed how much hospitals got paid. Remember, politics is the influencing of the allocation of scarce resources. And when Medicare and Medicaid went in 1965, it altered how those scarce resources went to the hospitals. There's also technological advancements and increasing population size in the mid-60s. So more and more technology, increased cost, more people, increased demand. And so professional registered nurses were at the intersection of conflicting forces. Hospitals wanting to save costs, nurses wanting to provide best possible care. And to save costs, a lot of hospitals eliminated nurses because in a hospital, the biggest budget is payroll. So the collective bargaining began in the 40s. In the 1940s, how would you like to work like this? Let's say you're working at your local hospital, and this is the conditions that you work under. You have arbitrary schedules, meaning day to day they can change your schedule. You do not get paid overtime, ever. No health care, no pension benefits, no sick leave, no personal time. 75% of you are going to work 50 to 60 hours per week, every week. Would you want to work like that? I mean, really, would you like that job? I wouldn't. 1946, the ANA approved a resolution that led to collective bargaining. Many unions have competed for the rights to represent nurses, and there still are many unions out there. But in 1946, that's when the unions started approaching nurses, groups of nurses, to offer to represent them. In the 1980s, the National Labor Relations Board stopped approving all RN bargaining units, meaning there used to be unions of just RNs. In the 1980s, that got eliminated. Now nurses are represented by unions that represent many different organizations. The service workers, I don't know, but it's Service Workers Union is a common nurses union. They also cover workers in fast food restaurants and restaurants in general. They cover maids and housekeepers in hotels and nurses. Coalition, by the way. That's a coalition, right? Diverse groups, different focuses, all working toward the same goal. So, what type of groups represent nurses? There are basically two types. There's the United American Nurses, or the UAN. This is, okay, United American Nurses, UAN, or the Center for American Nurses, the CAN. United American Nurses, Center for American Nurses. Now they have two different focuses, two different methods of representing. Groups within the UAN are traditional. Traditional. Traditional equals unions. So the UAN is traditional bargaining using unions. The CAN, the Center for American Nurses, is, well, that's traditional. This one is non-traditional. So if they're non-traditional, they're not going to have unions, right? That's correct. What do they have? They have a different concept called shared governance. UAN is traditional with unions. CAN is non-traditional using shared governance. What is shared governance? Well, shared governance is when nurses form a committee or a group within the hospital and legitimately form. It isn't like a bunch of angry nurses out to sabotage things. This is a legitimate organization supported by the hospital, and it's nurses that are trying to define and guide other nurses. In Aurora, those of you that live on the west part of the state, you don't have Aurora systems, but those of you that are LTC students, you may work or have been in an Aurora facility. They have what's called the ASNA, or the Aurora System Nurses Association. And that's a shared governance organization. Each hospital has their own ASNA group, and then there are representatives from that group that go to regional ASNA organizations, and then they get together for the entire system-wide ASNA. That's how nurses are able to bring research up the chain of command relatively fast and make changes happen far faster than traditional. I remember working when I was at Aurora on our ASNA committee. We did not have many pediatric patients at all in our hospital, very rare. But once in a while we did. And once we had a pediatric patient come in, and he was ill. He needed a blood transfusion. And we looked up in the book, because policy and procedure, that tells you how to do stuff, right? So we looked in the P&P to find out how fast you give blood to a 2-year-old. There was nothing anywhere. Nowhere. Nothing. So our group said, this is a problem. Even though we don't get PEDS patients very often, this is a problem. We need to be able to do this. So our group researched pediatric transfusion rates. We met with doctors, oncologists, pediatricians, intensivists, got their input and opinion, and we created a rough draft that we sent up the chain of command, and it got actually implemented. Nurses did research using a PICO formatted question: population, interest, comparison, outcome, to get a new plan for nurses. Shared governance. The management of the hospital didn't tell us to do that. The doctors didn't tell us to do that. The nurses said, we need to do something, and they did that. Now, that's different than unions. A union won't necessarily create new policies and procedures, but a union will make sure that you get paid correctly for the hours you work, make sure that you get the correct benefits that you were hired under. Those of you, is anybody here part of a union? See, when you're part of a union, you sign a contract for where you're working, or you're given a contract, which specifies in detail what you do, what you don't do, what benefits you get, what you won't get. So a union will make sure that you get what you're supposed to get. If you have a problem, let's say you are under suspicion of something, a union will provide representation so that you don't say or do things that may be incriminatory. Much like a lawyer, if you were suspected of a crime, you would go to the police station, you could have a lawyer with you to make sure you don't say anything that could incriminate you. That's what a union would do there. So, which is better? Which is, it depends what you need. They have different focus, but they are both designed to make sure that the nurse's job, the nurse's position, is protected. Now, obviously, there will be some overlap, some common issues. So what are some common issues? Let's do this in a different color, make sure it stands out. Common issues: staffing. Everybody wants to make sure we have proper staff. Professional performance. Objection to assignment. Now, what does that mean? Objection to assignment is a document or a form that if you are given an assignment that you feel is unsafe, you want to officially object to that assignment. You are not going to just say, I'm done, I'm walking out, because that's called patient abandonment. Objection to assignment says, on paper, I was given this assignment, I think it is unsafe for these reasons. You sign it, you give it to your manager, you keep a copy. What does that do? It does a couple of things. First off, it makes sure that management is aware that maybe mistakes are being made in staffing issues. But if something were to go wrong, it won't necessarily protect you. If you have a malpractice event, if it's true malpractice, that paper is not going to help you. But if something goes wrong, despite your best efforts, you can go back and say to management, I told you this was unsafe. I told you that this might happen, and it happened. What that does is, if you're sued, you have objective evidence that respondeat superior is in play. Remember? Respondeat superior, the master is responsible for the actions of the servant. In this case, you've demonstrated, you have on paper, that you foretold that this assignment would be a problem. And then it was a problem, and now you can say, I'm sorry, I knew this was going to happen, my managers made me do it anyway, this is more their fault than mine. Will it 100% protect you? No. But it sure is going to look good in court when your attorney pulls this out and says, on this and such a date, management was told. Right? So, both groups support that. Health hazards. Health hazards. One of the things that with that is they got latex gloves out of hospitals. Many people were developing latex allergies. Get them out of the hospitals, that helps. Here's a big one. This is the big important one. Clinical ladders. A clinical ladder is a defined path for nurses. You might be hired as, let's say, an RN1. And then you get your BSN, and that makes you an RN level 2. You get a master's, or you become certified in your area of expertise, RN3. Maybe you get a master's, maybe you get a PhD, whatever. But there are specific steps in terms of going up the ladder of your profession. And commonly, those steps also result in higher pay. Now, you will all graduate, pass the boards, and become RNs, associate degree RNs. A new RN with an associate's degree will generally be paid exactly the same as a new RN with a BSN. But in facilities that employ clinical ladders, they may differentiate between those different steps with pay. And negotiations. Now, in a negotiation, what's the union's big stick? What's their big weapon? A strike. Shared governance doesn't have striking authority. You know, as ASNA, we could not say, we're going to picket because we don't like what we're doing. But an ASNA group can say, the nurses as a whole feel this, and we think this should be done. Now, management does not have to listen to us. Right? They don't. But think about it. If all the nurses in a hospital said, we don't like what you're doing, and we think this would be better, do you think management might listen? I think probably. Okay, let's pause this right now. We're going to come back for the last section, I think.